Good morning, everyone. My name is Sachin Gupta. I'm the scientific director at ASCP. And with me today, we have Dr. Daniel Matman. He is the assistant professor in the Department of Pathology at University of Kansas Medical Center. So we will be presenting you today some of studies, what we did at ASCP to really understand the gaps and barriers and best practices for promoting the diagnostic excellence in the process of improving the communication of urgent and significant unexpected diagnoses or findings in anatomic pathology. So here are the speakers, as I mentioned. Some housekeeping items to keep in mind. Recording is in place, and I believe this will be available on demand. And we are not sharing any PHI or PII information, and presentation slides are loaded on your app. Dr. Matman and I, we do not have any disclosure relationship to disclose, and I just want to thank Gordon and Betty Moore Foundation for this grant opportunity, and CMSS, which is the Council of Medical Specialty Societies, for actually administering this grant. So it was a great project to work with a group of a number of people, as I mentioned. So again, thanks to our grant sponsors. So the learning collaboratives, so what we are expecting from this session today. Basically what we will be learning today is what are the urgent and significant unexpected diagnoses in anatomic pathology. We will be discussing the current guidelines and practices, what we use for the communication of these findings. And then Dr. Matman will discuss high priority communication barriers and gaps in processes for the communication of these findings. Then we will discuss the best practices, which we included as a group, and recommendations for the effective and timely communication of urgent and significant unexpected diagnosis. And last but not the least, the quality assurance methods, which are, of course, required to make sure we are in compliance with all the standards for these diagnoses. So the overall objective of this project and this study is to promote the role of pathologists and lab professionals in advancing diagnostic excellence along the diagnosis to treatment trajectory. So just to give you some background on diagnostic excellence and diagnostic errors, according to the National Academy of Medicine report, diagnostic error is basically the failure to establish the timely and accurate explanation of the patient health condition or the communication of that problem to the patient. And as a matter of fact, most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. When it comes to the anatomic pathologies, just to give you an example of how a diagnostic failure can occur in an anatomic pathology process. So let's say if there is a pathologist reports in unexpected finding on a case, and then the pathologist try to reach out to the provider, to the ordering or treating physician to report that unexpected finding. Let's say in this case, the treating physician is not reachable, right? And then what happens, that delays the communication of that finding to the clinician. Moreover, it also delays the treatment of the patient, in that case. So this is just one example where there's a gap and barrier in the communication, right? And we see that, as I imagine you are, a number of you are pathologists, you see that, when you're try to reach out to the treating physician, either you are not able to reach out or there is a gap in that communication, there is a barrier. And not only that, there are still some unanswered questions. I know we have a standard in place, we have a CAP standard and Joint Commission standards in place, but there are still some unanswered questions like what are the urgent and significant unexpected diagnoses in anatomic pathology? Are all unexpected diagnoses urgent? Why is notification and documentation of these diagnoses are important? And how should these findings be communicated in an effective and timely manner? So we'll try to address all these things today, and we'll try our best to answer some of these questions. Now, talking about the diagnostic error, there's another term called diagnostic excellence. So the Gordon and Betty Moore Foundation, basically, they created this term, diagnostic excellence, and the idea was not to focus on diagnostic error. Rather, the goal was to focus on the process, diagnostic process, and make it so good that the error doesn't occur. So they thought that a diagnostic excellence process should be ideal, right? Like there should not be any issue. It should be like smooth, and that way there will not be any diagnostic error. They thought that the process should be optimal and accurate and precise diagnosis can be rendered to the patient. And diagnostic excellence basically embraces 6 dimensions where they define that the care should be safe, effective, patient-centered, timely, efficient, and equitable. So these are the 6 dimensions which diagnostic excellence embraces, and this was actually our pillars where we started this project to make sure we actually consider all these factors into the study. So as I said, I gave you an example of a diagnostic error in anatomic pathology. We understand there are barriers, there are gaps in the communication of these findings. With that goal in mind, we at ASCP created a learning collaborative group where we actually convene a number of pathologists from different practice settings serving diverse patient populations. And we, as a group, participated in meetings to discuss current guidelines, current barriers, current practices for the communication of these findings. And then we facilitated group discussions and in-meeting polls, and we tried to understand each other's process. Okay, at site A, we have this process. At site B, we do this. So we tried to look at the literature. We tried to convene and come up with these barriers and gaps for the communication. And then at last, we proposed some best practices for the effective communication of urgent and significant unexpected diagnosis in anatomic pathology. So just go to the polls. It will really help us later to understand the audience. What is your primary healthcare role? The second poll question is, do you currently notify clinician of urgent and significant unexpected diagnosis in anatomic pathology? Third poll question is, do you understand the distinction between urgent and significant unexpected diagnosis in anatomic pathology? And fourth poll question is, do you experience any barriers or gaps in the communication of these findings? And with that, I will invite Dr. Mattman to talk about some current practices, what we did as a group, and some of the best practices we will be sharing with you all. So with that, Dr. Mattman, please.
Hello, so my name is Daniel Mattman, and I'm a pathologist at the Kansas City VA Medical Center and an assistant professor in the Department of Pathology at the University of Kansas. So as Dr. Gupta said, the ASCP assembled a group of us from diverse practice settings to come up with definitions for these things, a list of examples, and then some best practices. So I'll start by going over the development of this critical value in anatomic pathology. So to start with, I'll just give a little background on the clinical pathology critical value. So as we all know, it's a well-established standard of care in clinical pathology. So in 1972, Lundberg defined it as a laboratory value associated with a life-threatening condition that requires immediate attention. And then CLIA 88, the Joint Commission, and CAP all require that a laboratory must develop and follow a written procedure for reporting clinical values. And the ASCP has published guidelines and provided examples of critical values. So all of this has led to improved effectiveness of communication among caregivers. And in 2008, the ADASP conducted a survey to try to identify some of these critical diagnoses in anatomic pathology. So this was one of the first things that was done in the development of this system for the anatomic pathology correlate of the clinical pathology critical value. And they identified completely unexpected malignancies in critical sites, and organisms in immunocompromised patients as the things that most of their members felt represented critical diagnoses. And they also looked at challenges in implementing this critical value in AP, and some of the things that were brought up were that it's not a numerical value like the critical value in clinical pathology. There are a lot more details to these diagnoses. So if you think about all the elements of the CAP cancer protocols, you have interpretive comments. And so for all these reasons, a bidirectional verbal communication via a pathologist is ideal. And in terms of time, so while in clinical pathology, critical values can mostly be communicated within 30 minutes, in anatomic pathology, because of the tissue processing, in most cases, this isn't even possible. And then there's little agreement on what constitutes critical. So another thing that they looked at was whether the term critical value is appropriate for anatomic pathology. So it was brought up that it may raise inappropriate expectations among clinical teams and regulators, it may place needless burden on resources and stress, and it may induce the development of unrealistic medical legal standards of practice. So rather than critical value or critical results, the terms urgent and significant unexpected were identified as the preferred terminology. And then in 2009, the CAP conducted a survey of 1,130 laboratories asking, how does your policy address anatomic pathology critical values? And as you can see here, 25% of laboratories did not have a policy, and 30% had a general policy without any specific examples. And then in 2012, the CAP and ADASP released a consensus statement saying that urgent diagnoses should be addressed as soon as possible, and significant unexpected diagnoses should be addressed at some point in a patient's course. They also said that each institution should create its own policy. The list of urgent diagnoses should be created in collaboration with clinical staff. The determination of significant unexpected should be at the pathologist's discretion. Urgent should be communicated in a reasonable time frame, and significant unexpected as soon as practical. That verbal communication is preferred, and that documentation is recommended. And now the CAP includes in both their anatomic pathology and cytology accreditation checklist items. So they say that significant and unexpected surgical pathology and cytopathology findings that significantly affect patient care should be determined by the pathology department in cooperation with local clinical medical staff, and communication to responsible clinicians is required with adequate documentation. And there must be a reasonable effort to ensure that the clinicians receive the communications, and the records must include the date of the communication, the time of the communication, the responsible individual communicating the result, the person notified, and the findings communicated. And since we were talking about how what's considered urgent should be determined jointly by the clinicians and the pathologists, this study from Cratera and Otis from the Bay State Medical Center in 2018, it looked at the agreement between pathologists and clinicians in terms of what should be considered alert urgent. And as you can see here, there was a lot of disagreement. Specifically, it was asked if the clinical history is not provided on the requisition, how should the pathologist determine if a diagnosis is unexpected? And as you can see here, the clinicians felt that in these cases, the pathologist should just assume any malignant result is unexpected and alert urgent, whereas the pathologist thought that the pathologist should use the EMR to make this determination. And then in 2020, 11 years after the previous CAP survey, only 5% of labs did not have a policy, so that was up from 25%. 66% indicated that they'd read the CAP ADASP consensus statement, and only 24% of laboratories used the CAP ADASP terminology. But the respondents felt that the division of these diagnoses into urgent versus significant unexpected, it makes sense in theory, but in practice, there's no difference in terms of reporting. So you can see that in terms of the method of communication, the time frame, and the documentation, it was similar for these two categories. And this is a study from Iran. So it was a survey of 5 labs there that shows that they're seeing similar things with no standardization for critical items and the need to develop more uniform norms. So in terms of barriers, there's disagreement about urgent and significant unexpected diagnoses. And so it's not just between pathologists and clinicians, but it's also between pathologists. Yeah, and there's variations in the policies from one place to another, and there's a lack of standardization and time requirements. And then who to contact, figuring that out and determining that can present issues, as well as handling failed communications. So this presents some opportunities. So these are some things that we're going to discuss and that we discussed in our group. So we're going to try to provide clarification of definitions, formulate a list of some examples of each of these types of diagnoses, and then discuss some best practices in terms of methods of notification, considerations for departmental policies, timely communication, documentation, and quality assurance. So in our group, our definitions that we agreed on for urgent diagnosis, we said a medical condition that constitutes an immediate health risk to the individual such that immediate action may be required on the part of the ordering treating physician. And for significant unexpected diagnosis, a medical condition that's not clinically expected or foreseen and may possibly lead to a change in therapy or follow-up. So in coming up with a list of some examples for each of these, we came up with categories that you can group these into. And so the urgent and significant unexpected diagnoses tend to fall into the categories of infections, inflammatory diseases, certain hematolymphoid malignancies, unexpected malignancies, and then change in diagnosis. So for urgent diagnoses, here are some examples that we came up with. So under the inflammatory category, you see vasculitides and glomerulonephritis, so things such as temporal arteritis, leukocytoclastic vasculitis, or crescentic glomerulonephritis. Transplant biopsies, so where there's acute GVHD in a specimen from a transplant recipient, or acute rejection in transplant biopsies, or biopsies showing toxic epidermal necrolysis or acute fulminant autoimmune hepatitis. And then some acute or high-grade leukemias or lymphomas, particularly APL or Burkitt lymphoma. And then for infections, infectious organisms in sterile sites or evidence of tissue invasion when infection was not suspected. And then some examples of some organisms that when they're identified, so acid-fast bacilli, pneumocystis, mucor, aspergillus, or herpes in a pap smear of a pregnant patient. And then findings that are indicative of perforation or fistula formation. So adipose tissue identified in endometrial curettage, mesothelial cells in endomyocardial biopsy, ruptured uterus, bladder, or other viscous, and bile and thoracentesis fluid. So for examples of significant unexpected diagnoses, so unexpected malignancy, so this could be a malignancy identified in a surgical specimen that's not typically removed for a neoplasm, so something like a hernia sac or an appendectomy or a cholecystectomy specimen, or when you have a suspected benign neoplasm that happens to have malignant findings, so for example, struma ovarii with papillary thyroid carcinoma. And then change in diagnosis. So when there's a significant difference between the rapid onset adequacy assessment reading and then the final FNA diagnosis, significant disagreement between a frozen section diagnosis and a final diagnosis, any amended report that would significantly affect patient care, and significant disagreement and or change in diagnosis between the primary pathologist and a consulting pathologist. So for best practice in terms of the method of notification, we didn't identify a single method. Any of the following could be used. So a phone call, in-person communication, email, or text. So anything that's allowing that bidirectional communication with confirmation of receipt. And then ideally, the ordering provider's name, so who you should be contacting, should be provided on the requisition form if possible. So this gets at that barrier that was brought up earlier about the difficulty in identifying who it is that you should be contacting. And then escalation. So if there are difficulties in getting in touch with someone repeatedly, escalating and addressing this with the practice or hospital leadership. It's also recommended that if possible, harnessing technology, so working with LIS vendors to develop the following tools. So tools for identifying cases that are needing a report outside the pathology report with the ability to override if determined to not be applicable, identification or notification of personnel who should be notified of the report and looped into the chat, a chat function built into the report and documentation of communication, tracking and documentation of cases where reports have or have not been read and by whom, and then reminders to both the pathologist and the ordering responsible physician in cases where reports have not been read and or communication of urgent or significant unexpected diagnosis has not occurred. So these are all things where one could potentially work with the LIS vendor to develop tools that get at some of these barriers that we've brought up. So best practice in terms of the policies. So an institution or practice should have a policy for communicating urgent and significant unexpected diagnoses in anatomic pathology, and the policy should include definitions of urgent and significant unexpected diagnoses, examples of diagnoses, timeframes for communicating the findings, and documentation requirement for notification of the diagnoses. And the best practice in terms of the timeline for notification would be within 24 hours and preferably on the day of diagnosis. Best practice for documentation of notification, so ideally in the pathology report or an addendum to the pathology report, and then the documentation should include the date and time of this communication, the mode of communication, the person notified, and then the name of the person notifying the result, which if it's in the pathology report, it would just be the electronic signature of whoever's signing that out, and then the findings that are communicated. And then for quality assurance, departments should design methods to track cases of urgent and significant unexpected diagnoses and documentation of communication, and information technology solutions such as the ones that we talked about earlier can assist in tracking such cases. So I'd like to acknowledge all of the following people who are the members of our group, Drs. Varsha Manucha and Govind Bhagat, who actually produced the slides for this presentation.
Thank you, Dr. Metman. So there are some resources, free resources. You can scan the QR code. We actually have the ASCP Diagnostic Excellence page on the ASCP website. If you go under education, you can scan it. And then we have this resource guide, which is a comprehensive document explaining all the barriers, gaps, and the best practices. And please, please, please feel free to share with your colleagues. The goal is, again, to improve the communication and improve the patient care. So we have the resource guide link, and we have the Diagnostic Excellence page link here. If you have any questions, please come to the mic, and Dr. Metman and I will try to answer those questions for you, please.
Just a small thing. I noticed you didn't have a lack of trophoblasts on a POC specimen on any of the lists that you listed there. Is there a reason for that, or is that just
Do you want to mention?
Yeah, sorry, I forgot to mention that these lists are not entirely comprehensive. So that happened to be something that in none of our practices was frequent enough that we had included it in the list, but I think that is actually a really good example. So if there is anything that people think of that's not on this list, it could definitely be included on the list at your institutions. But yeah, as I was saying, we're just providing some of the most common examples. At each institution, you can customize these lists and add whatever would be most relevant.
And actually, I would like to add, thank you so much for this comment. If you can please go to the resource guide, there is a feedback form onto the resource guide. If you would like to add that to the feedback form, we would like to go back and add to the document. Dr. Brown?
Yeah, I think it's worth noting and important to mention when you look at the accreditation standards that there is a requirement, I believe, for critical results notification and AP for there to be a policy, but there's not a lot of guidance or specificity around what that should look like. I think probably by design, right. Which is not necessarily a bad thing. How do you see the balance between kind of that vague outline that it has to exist and that kind of leaving people hanging a bit, but then not trying to be too prescriptive where it could potentially be sort of like a litigious situation or something like that? Where do you see this initiative kind of on that spectrum?
That's a very good question. Let me answer, and then please, Dr. Medman, you can add. When we started this project, we knew there are some gaps, right? We do have a CAP standard and around cytopathology and surgical pathology, and we have a joint commission requirement also. But it was in my opinion, it's not that descriptive, enough. That is why we understood that there are gaps, and there has to be a descriptive guide to really guide the pathologist. I am hoping that with this document and with the voice of all people around, the CAP and the Joint Commission will be able to modify their requirement. I think that's where we will go in future. So to add more descriptive and more inclusive of, for instance, these examples. Right now, the CAP standard doesn't even describe what is the urgent, significant, unexpected diagnosis. What are the examples? What pathologists should look for? How they should be communicated? So there is not any guideline or any guidance on these methods. So we are hoping with this guide, with this education, hopefully we will try to see that CAP and Joint Commission will be able to add more guidance to their standard. And Dr. Mettman, do you want to add anything?
No, I think you actually covered it.
Okay, yeah. Did that answer the question, Dr. Brown? Any other? Yeah, please.
On another, something that also made me think of, when I first started practicing, we had an EMR that was rather archaic, and I felt like most clinicians, particularly surgeons and stuff, they didn't put anything in the EMR. There was it was really hard to get any sort of clinical information. You really relied on what came on that little card, the paper card that came to the lab. And now, 20 years later, I want to say everyone, most people are practicing in an environment, unless they're in some sort of a reference lab situation or really in maybe an underserved area that has a fairly robust EMR, that there's a lot of documentation. Because now people have to document in order to get paid, right? So that's a good thing. And so likewise, back in the day, right, I had to pick up the phone and try to track somebody down or maybe email them, but there was certainly no secure chat. There was no messaging function within the EMR to notify someone. I mean, I signed out a case a couple of weeks ago, and I just got in secure chat and said, oh, FYI, Mr. So-and-so, you thought it was esophagitis, but it's adenocarcinoma. And they said, oh, great, thanks. Not great, but thanks, and I'm going to pass this on. And then there's that documentation built in there. So I feel like we would always put it in a comment, Dr. Brown notified Dr. Smith at 10:47 a.m. of this diagnosis, and it would go in the patient report. And now maybe there's not so much of a need for that because it is documented in the medical record.
Right.
I know when I sign out, I try to make my reports maybe a little less complex because I know my patients are receiving those reports and just thinking about what do I not have to put in. But just wanted to make that comment. I guess it's not really a question, just another way that this is evolving and will continue to evolve. It's hard to make a best practice because the mechanisms in our practices are changing so quickly.
Right.
But I don't know if anyone had any sort of example like that or anything that they wanted to bring up about their individual practice setting.
In Epic, we can send out an Epic message, and it will notify us if it hasn't been read or, quote, done. The doctor has to actually press a button and say it's done.
Right.
So I don't know if we need the doctor to verbally respond or just that we know the doctor looked at their private Epic message, and that seems to be adequate for most situations that are not urgent, but the unexpected ones. The urgent ones, I think we have to, there is some time limit in some of these cases that you might want to make sure they got it in a timely manner.
Yeah, and I would like to just add, like with the Epic, there is definitely a need of enhancements, these LIS technology function enhancements and solutions. In fact, as a matter of fact, I happened to talk to the Epic team, their developer, the IT developers, and they are now prioritizing, after we mentioned that we are working on this project, they are prioritizing the critical value, sort of flagging for the AP values. Results in the Epic. So, for instance, again, I don't know how it will happen, but I'm imagining, like, let's say if you are, as a pathologist, you flag a certain result as a urgent or significant and unexpected, so it will flag red on the clinician side. And the clinician will be able to click on it, immediately see it, and they will be able to acknowledge it. So there is no need of a call, so to speak, because it's already been documented through the EMR, through the LIS EMR interface. So that is kind of solution we are looking, because we feel like, I understand there are certain requirements which are good, but if these things can be done through the IT interventions, then we might not need to do it. Again, talking about the technology, and we are in the AI world now, so why to waste tracking a clinician when these things can be done through the IT solutions? So these are some of the advancements we did talk about as a group, and that is why I talked to the Epic team, and they are now prioritizing their CV notification template.
Yeah, I'm thinking as these electronic solutions become more widespread, I think there used to be also more of a reluctance, like when these papers were initially coming out, saying like, oh my gosh, how many cancers did I get today? And I have to call I had to track people down and call someone about every one. I mean, what if they knew this woman had endometrial hyperplasia, an ultrasound, just because it's endometrioid adenocarcinoma? Do I have to track down the GYN, who's in clinic or in the labor unit, just things like that. And now maybe it's a good time to put some more robustness into what these criteria are for notification, because it is easier, in fact, to notify and know that you've provided an effective notification for many people, not for everyone still, of course. I think there's still disparity there, but I think that's part of the discussion as well, what's best for the patient, and that it's more feasible now within many of our practices to do things like that.
Right.
And it was
as a
cool
matter
in
of
our
fact,
group, in our learning collaborative group,
Yeah.
people actually said, oh, in my Epic build, because we all know,
Yeah.
we may all have Epic, but it looks very different between sites, but that something like this, like
Yeah.
Sachin just mentioned, was possible, and everyone's like, tell me who is your, and they could all kind of share. So that's kind of the beauty of having a learning collaborative. We're very grateful for this grant funding to really share best practices, and I didn't know that was available out there either. I've never seen something like that in any of the sites that I've worked in that has Epic. And so we're able to then publish it in resource guides and et cetera.
Yeah, and as a matter of fact, just I'm thinking like at my previous institution, we had Cerner, LIS. We actually created a drop-down menu. So let's say as a pathologist, when you are signing out a case, you will be for each case, it's by accession prefix basically. Like if you are signing out a case, you will select, is it a routine, is it a urgent, or is it a significant unexpected? So basically what it does, the flagging cascades out the follow-up process. So let's say if it's an urgent diagnosis, right? Then there is a notification of results section which pulls up in your report, and it is a mandatory field to fill out by a pathologist. So you need to document who do you talk to, what did you talk to, and the date and time and all that, so all the requirements. So that is one way to be in the compliance with the standard. But also, as we talked about the quality assurance piece, which is more like a compliance, because when the CAP comes for inspection, let's say they ask for, okay, show me your unexpected or show me your urgent diagnosis list. How will you track down those cases? It is not possible, right? Think about it. So if we are flagging one way or the other, if you're flagging these results in your LIS, then we should be able to pull those results, that list easily and show them, okay, here's the list, these were the urgent diagnoses, and you can show how many of those urgent diagnoses we have been communicating and documenting to the clinician. So again, these are some of the things that is why I think IT interventions are so important. And as Dr. Brown mentioned, with the EPIC, I think they are one step ahead, where they can flag, and it can be like a red color or orange color depending on the normalcy of your result. It can be on the clinician side, they can see that. So there's definitely advancements compared to what you were mentioning, right, many years ago.
Not that many, come on now.
Not many.
I'm just wondering, out of the folks here, how many of you have a robust, you feel like it's a very clear plan for how these types of diagnoses are handled within your departments? I mean, that's what I've never practiced anywhere really that did either. Do you see the need for that, or do you feel like this is onerous? Does it seem practical? And I know a lot of us do this, right? But then the guy sitting in the office next to me might do it completely differently, right? I mean, even within one group, there's often a lot of variation. And maybe on Wednesday, I'm super busy and I don't do it like I would have done it on Monday. I mean, I think that's true of my practice. And then I kind of look is this something that I should or not? No, it's probably fine. I mean.
I'm going to play some devil's advocate here. If you send out too many notifications, it'll be just buried. Really important things will be just buried down there. I practice surgical pathology in Korea, and I was trained in the United States again, and now I'm practicing forensic pathology. So I was in a different environment with different systems and stuff. One of the institutions that I practiced had whatever carcinoma goes to surgeon's EMR and blink, adenocarcinoma, blink. And the colon biopsy can happen like 10 adenocarcinomas. The 10 adenocarcinoma is blinking in his email. After 10 days, he'll ignore any those blinks, and nothing gonna happen. So really important things will be buried down. As a forensic pathologist in our EMR, acute kidney injury as a forensic pathologist, you'll alert our office, but we know acute kidney injury, quote unquote, just happens in any bad situation patient, so it doesn't really need to be blinked in our system. So I concern those robust follow-up can just bury everybody into another clerical work and not really advocating those really important things that you may have, I don't know, one a day or one a week. I mean, really important thing doesn't happen that often, so make that as a routine. I don't know, it just can be somewhat burdensome.
Yeah, that's a great point.
Yeah.
And I think there's a lot of debate about, do you report every new malignancy? Like if I have a tray of derm, I mean, am I going to call out every basal cell? Probably not, right? Or if you have a resection, but there's already been a biopsy, but maybe it wasn't at your organization. Now, is this a new malignancy once the colon comes out, but they already knew the patient had cancer? So there are a lot of, I think, debates and eliminating a lot of that background noise. So I think that's a fantastic. And the blinking seems crazy. I don't know about blinking.
But thank you so much, everyone. Have a good rest of your day and safe travels. Okay, thank you. Thank you, Dr. Mattman.